Good morning. This webinar, The Case of the Use of Human Milk, is hosted by the Minnesota Breastfeeding Coalition in partnership with the Minnesota Department of Health Statewide Health Improvement Partnership Program. Thanks to our speaker, Dr. Nancy Fahim, who will introduce herself. Please also see the accompanying webinar about starting a donor human milk bank in Minnesota called It Starts with Moms, which is also available on the same channel. Dr. Fahim?
Thank you, Linda. My name is Nancy Fahim, and I'm an assistant professor of pediatrics at the University of Minnesota in the Division of Newborn Medicine. I've grown to have a passion about breast milk and the use of human milk, and although I've been practicing for 15 years or more in neonatology, the more I learn about breast milk and the use of it, the more I'm impressed, and there's just so much to learn. And I'm hoping that what we can cover today is first to discuss what is it that's so unique and about breast milk and the benefits that it's offered from human milk, and those properties and benefits, how do they affect the outcomes in term babies, in preterm babies, and newborns in general, and in the mom and in the society. And because of the effect on these outcomes, how it helps in the cost benefit. So what is it about human milk? First, it's species specific. It's from humans to humans. It's the best quality as used for a reference, normative reference for growth. So I like that picture above. That ape is from Como Zoo. Arlene, the baby, was 2 years old when I took this picture at Como Zoo, and her mom was still nursing her. So even animals realize the importance of milk for their own species, and at that time she had just started weaning her off. So it's been around for as long as we know it, again, species specific, and we use it for the reference for normal, healthy term growth. So the growth curves made by the World Health Organization looks at healthy breastfed term infants over 6 continents and follows their growth over the first 2 years, and that is what we use for the reference to norm. And it's now, there is a surplus of evidence. It's documented. There is short and long-term medical and neurodevelopmental benefits of breastfeeding. Because of all of that, the American Academy of Pediatrics and several other organizations recommend exclusive breastfeeding for about the first 6 months. So no other food or water, just breast milk is sufficient. So what is it about human milk? I like this picture above. Under the microscope, on the left is a drop of formula, and on the right is a drop of human milk. Very different. It's a live substance. So initially we looked at the quality of the nutrition, but it's not just about the nutritional value and the quality of the nutrition it offers, but it's a live substance. There's immune cells, white blood cells, there's fat globules. It looks very different from a drop of formula. What we're realizing now over the last 2 or 3 decades, there's been a lot of studies that the importance is equally important to the nutritional value is the non-nutritional components and the cellular components, offering immune properties and anti-inflammatory properties. So there are hundreds of substances in donor milk and human milk that are not present in formula. For example, the cytokines, immunoglobulins, lactoferrin, lysosines, oligosaccharides, long-chain fatty acids. There's hormones, there's growth factors, there's digestive enzymes, a long list of substances that are that are unique to breast milk. I like the term, hearing that colostrum, that first milk, is an important transition from the intrauterine environment to the extrauterine environment. So the gut is exposed to amniotic fluid inside the uterus. When the baby comes out, or the first thing it should be exposed to is that colostrum in place of the amniotic fluid. So because of these biological aspects, so again, it is an important nutrition, it's a quality of nutrition that it offers, but it offers host defenses against infection. It modulates the immune response, and it helps modify the intestinal bacterial response. So we see all the benefits in because of this immune response, we see all the benefits in term infants. It reduces childhood infections, respiratory infections, recurrent ear infections, gut infections. Some people call it the first vaccine in childhood because of the protective effect that it offers. But it's not only infections, it also helps against autoimmune diseases, atopic diseases, so less asthma, eczema, we see less. It helps protect against type 1 and type 2 diabetes. It even helps protect against some sort of childhood cancers, 20% reduction in leukemias. Additionally, it helps in decreasing sudden infant death syndrome, breastfeeding and breast milk, up to 30% reduction in sudden infant death syndrome. And it also, in addition to all the protective effects, it actually helps improve the cognitive outcomes. There was a large study in Belize looking at 3,000 term infants, and they followed them to school age, and there was an improvement in IQ scores and teacher reports in children that were exclusively breastfed for the first 6 months. So again, there's a lot that we're still learning about breast milk, how it offers that protection, how it helps improve the neurodevelopment. Now, what about, we were talking about breast milk, what about donor milk? Does it still carry some of the unique properties of breast milk? So we do know that with pasteurization, there is some loss of these protective factors, but there's still a lot of biological properties that are retained. So for example, we can see that still more than 90% of oligosaccharides are retained. They are heat resistant. A lot of the vitamins are retained. Some of the cytokines, immunoglobulin, some of the cytokines like interleukins, interleukin 8, interleukin 12, growth factors are retained. More than 90%, and some factors still retain about 50 to 90%. There is some loss, but there's some retained factors like immunoglobulin A and immunoglobulin G and some of the interleukins. So in spite of loss of some of the properties of breast milk with pasteurization, there is still a lot of properties that are retained. So I talked briefly about the properties of breast milk and the benefit in term infants. What about preterm infants? In addition to all the health benefits that term infants receive, for preterm infants it's especially important because there are a lot of benefits, but what we see and has been repeatedly documented is a significant reduction in necrotizing enterocolitis, or NEC, and I will talk briefly about that in more details. We also noticed there are some studies that show decrease in late onset sepsis and improvement in reaching full feeding volume sooner and improving feeding tolerance. And also we see significant neurodevelopmental outcome improvement. Actually, there are several studies now that quantify the amount of breast milk that the baby receives, human breast milk that the baby receives in the NICU or in the newborn period can be correlated with the degree of improvement in outcome and IQ outcome when they are older. Like for every 10 milliliters of human milk that a preterm infant receives in the NICU can be correlated by about a half a point improvement in IQ. So it's dose-related. It's not all or none, but the more they get of breast milk, there is more improvement in their IQ outcomes. So what is necrotizing enterocolitis? That is one of the reasons we want to give human milk for the preterm infant. So it is one of the most common and one of the most devastating gastrointestinal emergencies that can happen or occur in the preterm infant. It's estimated to occur up to about 12% of premature infants weighing less than 1,500 grams. And of those, it's a very serious disease. About 30% of them will not survive. Half will need surgery, and half of those that go into surgery will not survive. And the ones that do survive have significant morbidities, short gut syndrome, long periods of IV nutrition or total parenteral nutrition, and they have significant neurodevelopmental impairment because this necrotizing enterocolitis is associated with an intense inflammation and necrosis of the preterm gut. We don't know the exact reason for it, but we do know that some of the precursors or independent predictors are prematurity, the premature gut, and formula feeding is associated with an increase in necrotizing enterocolitis. So we do know, and the studies have shown, that human milk is protective against necrotizing enterocolitis. Again, some studies up to 58 to 77% protection. One of the factors I thought this was interesting, and one of the areas of research, is that human milk oligosaccharides, in addition to several other components in human milk, might be protective against necrotizing enterocolitis. What are human milk oligosaccharides? We know that they are the third most abundant component in human milk. They are complex sugars, and they resist digestion and they resist heat, so they are not affected by pasteurization, or mostly not affected by pasteurization. There are more than 150 different types of human milk oligosaccharides, and their interpersonal differences. It's like a fingerprint, and hence it might be beneficial in donated milk that milk is pooled from several donors. And we know that it had effects on the infant. We know that it's a prebiotic. It helps growth of the good bacteria, the bifid bacteria, so it has a bifidogenic factor. But now we're realizing it also has antimicrobial effects, and it has an anti-adhesive effect, antimicrobial. So in general, it helps in the immune cell response modulation. And in animal studies in rats by Dr. Lars Bode, he has shown that HMOs do help the survival and reduce NEC in animal models, and with specific types of HMOs. So could they be playing a factor in protecting against NEC? That is the thought process at this time. So we realize all the importance of human milk, especially mom's own milk. What about donor milk, moms that have extra milk and donate milk? We know that for preterm infants, studies have shown that moms of infants that are born extremely low birth weight might not be able to supply 100% of the infant's need. Actually, in several studies, only 30% of moms were able to supply all their preterm infants' needs. 70% of infants did need supplementation. So when preterm infants need to be supplemented, what is the best choice? At this point, what the studies have shown is that human donated milk significantly helps in reducing necrotizing enterocolitis, and over the last 2 decades, it has gradually become the most acceptable form of supplementation in addition to mom's milk when it's needed. So briefly, I want to touch on some of those studies. So there were 3 recent meta-analyses that all showed significant reduction in necrotizing enterocolitis in preterm infants that were fed donor milk versus preterm formula. There was recently, in 2013, Dr. Christoffel and her group randomized infants to a trial of exclusive human milk, so donor milk with human milk fortifier versus preterm formulas in moms who did not provide any of their milk. And again, what they noticed was a significant reduction of NEC. 20% of infants receiving formula developed NEC. Only 3% of those receiving donor milk developed NEC. And there was also a significant reduction in the days of total parenteral nutrition and reaching full feeds. One of the most recent large trials was published in Canada, the Domino trial, or it was donor milk for neurodevelopmental outcomes. So we have noticed the difference in NEC, but does that donor milk offer the same protective, the same effect on neurodevelopment as mom's own milk? So this trial looked at 360 infants, about 363 infants. Half of them were supplemented with donor milk when mom's milk was not enough, and half of them were supplemented with formula. The goal was to look at neurodevelopmental outcomes, but what they noticed is that there was still a significant reduction in NEC. At 18 months, they could not find a significant difference in neurodevelopmental outcomes between donor milk and formula. So it might not offer the same benefit on the growing brain as mom's milk does, but still there was a significant reduction in necrotizing enterocolitis. Now, regarding the Domino trial, they are close to looking at 5-year outcomes for neurodevelopmental outcomes for those that receive donor milk versus formula, so still more information to be seen. In another study that was published in 2018, again, donor milk helped decrease NEC by about 26%. So many articles are, and the evidence is growing that donor milk appears to help protect the infant's gut against necrotizing enterocolitis, as mom's own milk does. And in this study, they also noticed that mom's milk, it improved breastfeeding rates, increasing it by about 10% at discharge. So the main focus at this point, or what studies have consistently shown, is reduction in necrotizing enterocolitis for preterm infants that receive donor milk. Other potential benefits, again, improved feeding tolerance, less days on TPN. Some studies have just suggested a reduction in late onset sepsis as mother's own milk, and there might be long-term benefits. Improvement in the lipid profile, blood pressure, possibly neurodevelopment. We still have to see about that. And again, it has shown when donor milk is available, it tends to improve exclusive breastfeeding rates at discharge. And this was again seen in an Italian neonatal network with improving in breastfeeding rates from 30% versus 16% when bank milk is available. Because of the benefit for preterm infants, the AAP statement was strong. It came out in 2012, saying the potential benefits are such that all preterm infants should receive human milk. And again, mainly because of that reduction in necrotizing enterocolitis. Mother's own milk is always the best. Should be fresh or frozen and fortified for infants less than 1.5 kilos. But if mom's own milk is not available, then pasteurized donor milk should be used because of all the accumulating evidence. So I wanted to touch briefly historical aspects of donor milk. So really early in the dawn of the 20th century, so early 1900s, almost all children received human milk. Either they received mom's milk or they, at that time, they hired wet nurses who had extra milk that would just automatically feed the babies when mom's milk was not available. Now, as as the milk analyzers started to develop in the late 1800s, infant formula started to be developed, and cow's milk was used not because it was close to mom's milk, but because it was available. Now, formulas continued to progress over those first 50 years, and unfortunately, by the 1950s or 1960s, at that point, most infants were receiving formula instead of breast milk. And even health professionals and hospitals were encouraging formula as a substitute for breast milk, and they promoted it as the method of choice. And I was looking on the internet, and there are several advertisements, like one showing in the slides, when milk's on the house, it must be the best. So it just shows everything that was wrong at that time, keeping the baby separated away from the mom, feeding it formula, feeding it with a bottle. So at that point, it was the most promoted as the best feeding at that time. And unfortunately, there was an increasing mortality with that and morbidity, and that's when the World Health Organization started to promote breastfeeding and came up with the 10 steps for successful breastfeeding. So what about donor milk? How was it progress in the last century? So in 1909, the first milk bank was established in Austria. In 1919, 2 additional milk banks were opened, one of them being in Boston, that was the first one here in the United States, and the second one in Germany. And gradually, it started to progress. However, in the mid-80s, with the appearance of AIDS or HIV, number of milk banks were dramatically affected and they were closed. And there were only about 8 or 9 milk banks by the 1980s. At that time, in 1985, the HIMBANA was established, which is the Human Milk Bank Association of North America. And its goal was to establish standards for all North Milk America banks. And so gradually in the 90s, with improving research, how to improve the safety, donor milk banks are again starting to grow globally. I found one of our colleagues, Dr. Dana Johnson, likes to collect old books, and I found this book published in 1941 by Dr. Julius Hess and his nurse, Evelyn Lindane. Dr. Hess and Ms. Lindane were some of the first pioneers for neonatology, and several authors look at Dr. Hess as the father of neonatology. So they started what was like close to the first NICU, and they realized that incubators and keeping the preterm infants warm was one of the most important things. But I came upon reading this chapter that he wrote about breast milk, and it's interesting what he wrote. He said, by far the best results for the premature infants that are less than 1,500 grams is when they are fed human milk. And this also applies to many of the larger premature infants. And he said we should secure mother's own milk, but when it's not available, a wet nurse or donated milk should be supplied because it helps with the survival of these premature infants. So it just took us about 80 to 100 years to realize what Dr. Hess had mentioned 80 years ago, that human milk improves the survival of preterm infants. So cost effectiveness. We had talked about how human milk, mom's own milk and donor milk, help decrease the incidence of necrotizing enterocolitis. How does that relate with cost? So necrotizing enterocolitis causes about 20% of neonatal expenditures, almost about $5 billion a year in the U.S. for hospitalization of preterm infants. If the preterm infant does develop NEC, for each case that is medically managed, roughly an estimate of a $73,000 increase in cost. and if that infant needs surgery, at least an additional cost of $186,000 with additional need to stay. So overall, another study looked at it, that NEC was associated with increase in a cost of at least $43,000 for each preterm infant after controlling for variables. So it's a very expensive disease. Now, how much does donor milk cost? One study looked at the cost of donor human milk per NICU infant, and it varied. They divided them in 4 groups. The first group being the group that moms were able to supply most of the milk to the infant, and it just needed a small amount to bridge that gap to donor milk, and it was about $27 per stay. And the 4th group, the moms that had no milk to offer, did not offer any of their milk, and the infant needed donor milk throughout the hospital stay, and it was about $590. So it's a very small cost to protect against necrotizing enterocolitis, which costs, as we had seen previously, costs in the thousands should the baby develop that. So the estimate is that feeding 10 babies with exclusive breast milk can prevent 1 case of NEC, and that is huge. Whoever had to deal with a baby developed NEC in the NICU, that is a huge percentage. And feeding 8 babies with exclusive breast milk can prevent 1 case of surgical NEC or death. So I'm almost done, but I briefly want to touch about our experience. So I cover at the University in North Memorial and Maple Grove. At the University of Minnesota, the NICU has been using donor breast milk to bridge the gap when mom's milk is not available since 2004. At North Memorial and Maple Grove, we started in about 2010 or 2011 in the NICU and the special care nursery. It was offered to all preterm infants that were less than 34 to 35 weeks, again, when mom's milk was insufficient or unavailable or the mom was unwilling. And at North Memorial, we opted to go further. We said donor milk will be offered for medical supplementation for any infant, not only less than 34 or 35 weeks, if the mom plans on exclusively breastfeeding. So we will offer that donor milk as a gap or to bridge the gap until mom's milk is in. And we started the first milk depot in the Twin Cities at North Memorial Hospital. And this has gradually grown to become 5 milk depots. So what is a human milk depot and what is the difference between it and a human milk bank? So it's an agency that's affiliated with a milk bank. Its main job is to collect and store donated milk from moms that have extra milk and they're screened, and that milk is transported to a milk bank for processing. And then we purchase the milk back from a milk bank. And the great thing is that we are in the process of opening a Minnesota milk bank to keep the milk bank from moms that offer it in Minnesota. And this picture on the slide is a great story of a young mom with 2 children. Both her children, 3 months old and a 3-year-old, were born prematurely. And they needed milk until her milk was sufficient. So again, it was used, pasteurized human milk was used as to bridge the gap until her milk was sufficient to cover for her children's needs. And she had excess, so she felt relief that they were offered human milk and was under pressure, and her milk supply increased, and she had a lot of extra donor milk. And she said, I just want to pay it back. I felt the importance of having it for my children, and I want to have it available for other children. And she brought in loads of breast milk for the milk depot. So our goal is hopefully to try to keep that milk here within Minnesota. So in summary, I hope that I've was able to emphasize the importance of human milk. It's the single most powerful intervention to optimize the health for all babies, term and preterm babies. Mother's own milk is always preferred. So the goal is to have mom's own milk. I hope I showed you that our neurodevelopmental outcomes and several other outcomes were mainly related to mom's own milk. And priority needs to be given to help moms to express their milk. When mom's milk supply is low and we need to bridge the gap, then pasteurized human donor milk improves health outcomes in preterm infants and should be used. Again, with emphasis on helping moms supply. And if we use donor milk, we should have lactation consultants available to help mom pump. But when it's not available and we need to bridge the gap, then we should use pasteurized human milk. Now, pasteurization does eliminate immune cells and other bioactive components, but several are retained, and studies have shown that it's protective against necrotizing enterocolitis. And with that, I'd like to thank you, and please forward me any questions with email. Thank you.